Can I shoot?
Sure.
I have a question about precision medicine. What's the role of immunosenescence in treating rheumatoid arthritis, and would senolytics make a difference?
Okay, so that's a great question. So immunosenescence describes the aging of immune cells, and as immune cells are getting older, they are less, if you like, responsive or manipulatable. And definitely there's some evidence that the lymphocytes in patients with rheumatoid arthritis have features of immunosuppressants. But at this moment in time, nobody has looked at the role of immunosuppressants as a biomarker of response.
You know, immunosenescence, in things I'm reading, looks like it's very nascent in where it is, and so its applicability is uncertain, but I see a lot of it being talked about in senescence in general, in osteoarthritis and degenerative diseases. Maybe that it may underlie some of that.
Well, we did some study before, particularly looking at the CD8 cells that has features of immunosuppressants. And what is clear is that for some individuals who have certain virus infections, particularly CMV before, the lymphocytes tend to have immunosenescence phenotypes. And for some reason, many patients with early rheumatoid arthritis have that phenotype. And our take is that the immune process in rheumatoid arthritis must have started many years before. Whether the patient has certain virus infection can modify that immune phenotype. But we don't know whether it's manipulatable, because immunosenescence is related to losing certain fragments of DNA. So you can't restore them very readily.
All right, well, a couple of questions have come in over the course of the morning, and nobody's really used the P word. No one said anything about prednisone in any of the talks. So, Jack, you talked about refractory RA, Kaleb about adherence, Ernest about precision. I'm going to put you all on the spot. Where does prednisone fit into the different aspects of rheumatoid arthritis care that you all have covered?
Kaleb, do you think patients are more compliant with steroids than they are with DMARDs?
Yeah. When they need it, yeah. So what we've seen is that, sorry, you sit down all day and on the plane, you want to stand up a little bit. When patients and the rheumatologists are working together to get them off steroids, because no patient loves steroids. I mean, they love the immediate effect of them, but the side effects are so extreme and real that everyone wants to get off of them if they can. Beyond you're going to die if you don't take these now, pulse dose levels. But as you're titrating them down, and you get to the point where, like, okay, 7 is okay, but 5 isn't, those patients tend to be really good because they notice and they see the difference. But it's usually only when you're actually having that conversation going back and forth where you can get to that level. But for the most part, patients are doing whatever they can to get off of them, and they're taking those because they've found that they can't really get by without them.
The data is bad about getting off steroids. I mean, the ICE Bio study, which we covered, is a study that looks at what rheumatologists really do in RA, PSA, and SPA prior to starting a TNF inhibitor or a biologic, and how much steroids they're on. You would think that starting the expensive, more effective biologic that patients would be able to go off of steroids, and in general they don't. And so we're all guilty of letting that go on and on. The question is, where are we going to have to go to get to a point where we're not going to be so reliant on steroids? The safety data on steroids is pretty clear. It's not just that 10 milligrams or 20 years of 10 milligrams is a bad thing. Even 1 milligram, 2 milligrams, 3 milligrams, studies in the last year showed higher rates of serious and hospitalizable infection, higher rates of cardiovascular events at doses less than 5 milligrams. So the day is going to have to come when we're going to have to get rid of using steroids, and the guidelines are saying that now. The guidelines don't want you to use steroids. The ACR guidelines, the JIA guidelines just came out say don't use steroids. I think we're going to have to go that way.
Yeah. So in fact, I was in the EULAR working group that work on difficult to treat RA, and failure to reduce steroid is one criteria as evidence of active disease that require management. So one of the criteria already. I think for precision medicine, if you want to think about it, for rheumatic diseases, The availability of monoclonal antibodies allows you to study precision medicine much easier, because to get precision medicine, you need to detailedly phenotype the patient on the one hand, then you need to map the patient with very specific intervention that affects certain pathway. With steroid, the problem is that it does so many different things. And then the problem also is that you study is that when you increase the dose, the biology also changes. So it makes it really difficult to do precision medicine using it as a tool.
And we found over 25 years of forward NDB that when the biologists came on board in 1998, what came down the most was NSAIDs. Steroids stayed around 30% still. The dose of steroids went down, but still the use of it was still prevalent, highly prevalent in the RA population.
And I think the last point about steroid that is really difficult is that we did a randomized control trial of depemedrine in regular injections of steroid many years ago. And there's definitely an immediate anti-inflammatory effect that you can see. But actually the groups of placebo and the active treatment groups start to merge together. So you start to lose some of the effect on the symptom. The effect on protecting the joint from damage stay, but the symptom improvement starts to decrease over time. And that makes doing the precision medicine very difficult.
One last note on this is that comorbidities play an important role because the other doctors who see the patients prescribe steroids, all the time. And the rheumatologist, I know exactly all the times I've gotten injections of steroids and taken the pills because it adds up. And for some reason, I'm osteopenic near osteoporosis. It's not because of my genetics and my history, and this is because of the steroids that I've taken in my lifetime. So, and that's one of the concerns that comes up when you're dealing with other doctors and not having that, group conversation on it.
And you can never cut people off steroids because all they have to do is go to Doc in the Box and say, I'm on steroids and I'm out of them, and they'll get another couple of months' worth in a prescription. Dr. Choy, we're asking, I put you on the spot. We were talking about steroids representing the UK and all of Europe, even though the UK isn't in Europe anymore. But do you all overuse injections or do we underuse injections here in the US? Because we look at studies like the Scandinavian study from last year comparing different mechanisms of action, and people were very liberal in the intra-articular steroid, which of course does give steroids. So are you guys using it too much or are we using it too little?
Well, we are pragmatic, as you know, we have been in the UK, and we use injections of steroid as a way of not putting the tablet in patients' hands. Because once you give them tablet, it's very, very difficult to get it off them to not prescribe again. Giving it by injection puts the doctor under more control, so you're more able to say no and avoid repeat prescription.
So is that paternalistic medicine instead of precision medicine there?
I guess that's just a pragmatic medicine. Pragmatic medicine.
Your adherence is near 100% that way. But
Yeah, you know you're going that, and you know that you will wean off automatically.
So a number of questions, I think, for Dr. Choy, but for the other panelists as well. Back to the synovial biopsy. How practical is it? Is there a role in the patient who has failed multiple medications, perhaps? Is it going to be something that we're going to see in routine practice?
No, I don't think it will be in routine practice straight away. I think there is still a hope that we would able to find with the modern technology everyday marker. But I think for the refractory patients, for the difficult to treat RA patient, maybe that would be a role in the future. What do you think, Jack? Refractory RA patient, based on what Maya said?
Boy, possibly, but I still think that's going to be an academic center exercise or referral center only sort of thing. I think that the value of biopsies, which should, they are valuable, and we'll get to the point. If we get to the point where we're doing precision medicine sort of investigation that's based on synovial biopsies, where we're using homogeneous patients that we can well characterize, we can get to the point where we can make certain decisions and then find surrogate markers that don't need to have us putting needles into joints and getting tissue that needs to be analyzed. That maybe, like you say, CXCL13, for instance, and other things that could be surrogates for what we're seeing with the cellular phenotyping or the even genotyping, that is probably where I see what the value of these investigations would be right now.
I think one of the challenge to think through, which I didn't allude to, is that sometimes we assume that RA state exactly the same disease as it is, but it's actually not likely to be the case. In fact, the longer the disease is, the more intervention we put in, the underlying inflammation, the pathology is likely to change with time. So the refractory RA patient's pathology may well be very different than when the patient first presents with rheumatoid arthritis, and that poses an additional challenge that we will have.
Mm-hmm.
As a double negative RA patient, I'd prefer the Kevin Dean approach, which is they just haven't found what you're positive for yet.
So speaking of that, and you showed some data we've known about for a while, Dr. Choy, how big a difference do you have to see for it to influence your clinical practice? Do you use the presence or absence of rheumatoid factor in your decision to use or not use rituximab or abatacept?
Well, that is a great question. We kind of use it because if we have other options, then we definitely don't tend to, in the double negative patients, if we have other treatment options, then we don't go straight to abatacept or rituximab. We'll use the other options first. But it doesn't mean that we can't cycle back to them afterwards. But it's not absolute cutoff, as I said. It doesn't actually say that if you are negative, then you won't respond. And when the patient have failed multiple biologics, what we see in our refractory RA clinic, then you may have to opt for those.
Jack, what about to Kaleb's point that they're positive for something we just haven't found? It may be carb-amylated proteins or peptides or other alterations related to the inflammatory milieu that they're in that we're just not commonly testing for. Or are these really distinct differences?
Yeah, I don't know what I don't know, and until I either search for it or inquire about it, I think, like the question about 14338, I think it has some value in some patients, but it doesn't, if you do RF and CCP and 14338, are you going to get, all the patients who are seropositive, and how many of those tests do you need to do to really find that? And it turns out that 14338, I don't think adds enough. There's a few, but I want to go back to well, I'll leave it at that. I think that the idea is that we're still going to need to be curious enough to want to know more about the patient that's not responding and how we can get better at treating them. The question is, where are you going to go? I like the construct I presented. It's wrong diagnosis, wrong drug, wrong patient, and consider it like that.
Okay. So we spoke about the guidelines and them saying about minimizing steroids. Someone says, can the ACR create a policy to discourage the indiscriminate use of steroids by non-rheumatologists? Every time one of my patients gets pneumonia or bronchitis, they give antibiotics in a Medrol dose pack. Whether it's indicated or not, it's very frustrating.
I mean, let's make it the job of the local police. I don't know. I mean, what the ACR has no power or importance. I mean, a campaign about this, ACR's campaign on smarter use of testing, how well has that worked? I don't know that I think it has had an impact. I think it's a nice tool for you to use when you're going out and talking to the community. But, and maybe that really is, maybe it's really our job. We all say that I'll take the phone call from the primary care. I know who my primary care referrals are. The problem is that we don't interact very much with the primary care. We don't tell them, these are the rules. These are the patients I want to see. If you have A, B, and C, I'll see the patient in 20 minutes. But you just hope that they're going to send you the right people and that's how you're going to collaborate. So if we were more proactive with emergency rooms and primary cares and referrals, then maybe we would be, and it's really a marketing issue. I mean, it's putting out there everyone, you think that they know what you should do, but I don't know that we really know that.
And that raises a point. Maybe Ernie can weigh in with the European perspective as well. I think your primary care doctors may well push back and say, well, your next appointment's 3 months away. What am I supposed to do? while the patient's waiting to get into the office to see you. Is that an issue? Is access an issue in the UK and in Europe?
Well, actually in the UK, we have a national audit at the moment, and the standard guideline is that patients need to be started on a disease-modifying drug within 3 months of onset of symptoms, not diagnosis.
Well,
so we all have to get to see the patient quickly, and that avoids the patient getting the steroid. The second thing is we don't tend to ask GP to treat the flares. The patient has a hotline to contact us when they have flares, so they come straight to us rather than going to the GP. So that's how the standard guideline, at least in the UK, is to take that management a bit out of primary care.
But the trend in the UK has also been that through these audits, you've seen that referral times to rheumatologists has gotten shorter.
Yeah.
And like you say, the time to start DMARDs has gotten shorter. So, having a national standard certainly helps.
okay. Then there's a report, Jack Lichtenstein published a report on elevated ASCA, the S. cerevisiae antibodies in seronegative RA. It's part of the microbiome. Has anyone else used this test? They use it for, our colleagues use it for IBD.
Yeah. Not obviously routinely rheumatically. We only just started on this journey, and I think we only started to get the idea that the microbiota is important. And I think there are increasing evidence that diet and environment would influence disease activity, and they probably work hand in hand with the powerful medication that we prescribe. So we start to tell us that we shouldn't ignore them.
Ernie, do you think that the microbiome is going to tell us more about what's happening with disease activity as a driver of disease activity, or is the microbiome more likely to color how drugs are, how we respond to drugs? I mean, we've got that example from oncology where it's the microbiome that predicts response to certain regimens, for instance.
Yeah, I kind of think that it may well work both ways because the microbiota can change. It's not fixed, right? So why don't we try to alter? But if you are a biologist, what you will want to find out is which are the good bugs, what pathway they are using, and what they are using to suppress disease activity, in which case you have a new treatment, even a new class of treatment that may work. So you can think of it in different directions as either generating new medication, but also encouraging a patient having a healthy diet. So I think it depends on what your fancy is, which direction you want to take the research.
I think we should start a company, Good Bug Biotics, and we use that to treat RA.
Well, it works for IBD, There are probiotics that are being marketed as being useful treatment for IBD.
So in a public service announcement with all this talk about the microbiome, for the people in the audience, there are a set of bathrooms right over here as well. We don't have to go all the way back toward registration. There are some right around the corner. We're just learning this hotel. So with that, let me thank our panelists very much, and thank you the audience here and virtually.